Welcome back to part 2 of learning module 5. We're going to go over chapter 10 about the assessment of lower body flexibility and low back function. So what is flexibility? Well, if we look at synonyms for flexibility, it states that it could be suppleness, give, elasticity, or plasticity. But then we have to look at what the textbook states as the definition as flexibility relates to the ability to bend without breaking. And if we really think about this, this is pretty generic. That could be almost any material at all. Now, if we go back to the NSCA's Essentials text, it's defined, flexibility is defined as the range of motion about a body joint. So let's look at it this way. Let's combine the two and state that flexibility is defined as the range of motion about all the body's joints as it relates to its ability to move without breaking or becoming injured. That's a little more conclusive definition of what flexibility is. Now, if we look at structure, function, and flexibility, no matter what program we start with, we have to learn structure and function first. We learn the bones, we learn the muscles, we learn how those muscles will fire from the nervous system to cause motion. We also have to look at all the muscles' origins and insertions, because if we know how they work, we'll know how it moves a lever or a bone. We also have to look at the muscles' architecture, because not all muscles are built the same. The fibers are completely different, and some fibers are really long, others are angled. So you get the picture here. So if we look at biomechanics, on one side is kinesiology, the study of human movement, and it consists of the kinetic chain, the nervous system, skeletal, and muscular system. And that basically is anatomy and physiology, or structure and function. On the other side, we have physics, rigid body mechanics, which is a category of physics, and that's broken down into kinematics and kinetics. Kinematics is any type of motion independent of the forces that cause it: acceleration, displacement, velocity, etc. It describes motion. On the other side are kinetics. These are the forces that cause motion. So that is what it's referring to when we look at the kinetic chain. Because we have the skeletal system, which basically is our foundation. Then we have the muscular system on top of that. But the only way to get the muscles to fire, to move these bones, is from the nervous system. That's the big electrical system. So if we don't know how the skeletal system is put together and how the muscles work, their origin and insertions, and how they cause motion, and how they produce force to cause motion, we can't really do a good analysis or assess motion as it should be. So because we have to look at all the joints within the skeletal system as well to look at its range of motion at each one of these joints. That's the only way we're going to be able to analyze, are we getting the proper range of motion out of each joint? Because if you have some multi-joint movement, and you have a deficit at one of those particular joints that are in that particular motion, if that's kind of tight at that one joint, it can affect the entire motion and cause it to be ineffective. Now, the foundations for analyzing movement come from, once you learn the structure and how it functions, we're going to take a concept and a statement from a book of Biomechanics, a qualitative approach for studying human movements by Piriformis and Bartels. And it states that concepts related to the motion of the body or the body segments and the cause of those movements form the foundation for analyzing movement, which is what we just stated. If you don't know how everything's put together and all the parts that are involved, how can you do a correct and efficient and effective analysis of movement? Understanding these concepts precede assessing flexibility. That should make perfect sense to you. Now, to completely appreciate and understand flexibility, one must know the following concepts and terms before assessing range of motion. This is structure, the kinetic chain, the function of the kinetic chain, any system within the body. So if you look at the muscles and skeletal systems, if you put certain bones together with muscles, they form specific systems within the body. And we also have to be able to know how this movement of that body or system works effectively. We also have to look at motion and the different types of motion. We also have to look at how these systems move through planes of motion. And if we look at movement through a plane of motion, what are the types of motion? Flexion, extension, hyperextension, abduction, adduction, rotation, or combinations of these motions, which will cause and are also described as multiplanar movements. Now, for structure and function, let's look at the kinetic chain. We have bones, types of bones, and the reference points on those bones where the muscles are attached to. We have to look at the muscles themselves, origins and insertions. We also have to look at the muscles' architecture. Are they longitudinal, fusiform, unipinnate, bipinnate, multipinnate? Because that will dictate the type of force and range of motion of that lever system that it's attached to and how it's going to move. We also have to look at the nervous system. The innervation of the nervous system or the motor neurons to the muscles and how these working muscles cause movement. You've also heard of the term muscle memory. Like if you do something, you learn this particular movement, but you don't work out for a while, and you start working out, oh yeah, people say, yeah, that's that muscle memory. Well, ladies and gentlemen, you have to realize that muscle, if I can be direct, muscle's pretty stupid. It doesn't store memory patterns. Now, if you look at that, if you look at a muscle, you lay it on a table, it's not going to work until you give it some kind of electrical stimulus. That's what comes from the nervous system. Now, the motor patterns that you learn are stored in the brain, not in the muscle. I hate to make this a big deal, but it's just kind of one of those terms that people use to try to understand it. But for your sake, you need to really learn how all of it works. The brain stores the motor patterns, which is what we do. Now, the systems, how they're defined. A system is a body or group of bodies or objects whose motion is to be explained. An example of those are like an arm, a leg, torso, or the whole body. The whole body actually is considered a whole system, but if we break everything down, look at the arms, parts of the arms or legs, that can be a particular system too. And also, too, that's the internal systems. If you look at external systems, we can look at a tennis racket or barbell. They could be systems as well, too. We could also look at the collision of two football players, two systems colliding together. So we really have to take a good look about what a system is. Now, if you look at the human body, it's composed of segments linked together at their articulations, i.e., those are the joints. Those are the things that we have to look at and what is their full range of motion. And a system of these movable segments or links, that is what the human body is composed of. It's a system of movable segments or links. And in the body, we have 11 functional links. Now, movement of a system within a frame of reference. A frame of reference is nothing more than a stationary environment or something that is moving. Example, if we look at the shoulder girdle, it's the scapula, the clavicle, and the arm. If we look over here at the first diagram A, the hands are fixed. So he's pulling the body toward the hands. But what about a pull down? The shoulders are fixed and the bar is moving. So that's a pull up versus a pull down. But it's still a specific system. It's just in a different environment with different frames of reference. Let's also look too at the shoulder girdle when we're doing an overhead press. The bar sits on top of the front deltoids and we're pushing the bar away from the shoulder joint, which means the shoulder is going to be fixed basically, but the shoulder girdle, the shoulder blades are going to move appropriately to position that socket. The arms will move at the elbow, the shoulder joint, and the elbow to position the bar overhead. Now let's look at orientation of the body moving in space. Movement of a body describes as being in a direction designated as X, Y, or Z. Now if you've had any kind of physics or any kind of mechanics in the past, if you look at 3 dimensions, we have X, Y, and Z. Sometimes if you look at a graph, it says that you have X is going straight across and Y is going up. That's a 2-dimensional space. But in this particular case, they think Y is going straight ahead, or X is going straight ahead, forward and backwards, Y is left and right, and Z is up and down. So if you look over here at the person swimming, they're moving forward. So that's X in a positive direction. If they were going backwards, it'd be Y in the negative direction. They're stabilizing in the Y direction, left and right, staying there, and they're trying to stay going from moving up and down. That would be in the Z direction. So if you look at somebody running straight ahead, they're going to be moving forward in the X direction, not going backwards, not moving left or right, which is in the Y, and they're not bobbing up and down in the Z positive or Z negative. X and Y are parallel to the ground. That's horizontal movement. Z is perpendicular to ground, which means that is vertical movement. Now, motions and types of motion. The basic definition of motion is displacement of an object moving from one point to another. That's all it is. And the types of motion we have are linear, which means straight line, or rectilinear. We have a curvilinear motion, a rotary motion, and then general motion. Now, linear or rectilinear is a path of an object is in a straight line. Curvilinear is the path of an object in a curved path. So if you look at examples of that, if we throw in a baseball or a barbell in the snatch movement, the ball or barbell will travel in a curved path, but its displacement or distance traveled is measured in a linear straight line. So if you look at the picture up there, the long jumper, this long jumper takes off, travels in a linear path, and then lands. But how do we measure that? From point A, by the time he takes off, to the point where he lands at, but that's measured in a straight line. But that's an example of a linear motion as well as curvilinear motion. Now this is the snatch movement. If we look, the barbell goes from the floor to overhead in one continuous movement. So if we look at these paths, they're going to go from point A, from the ground, to overhead to point B. But the paths of all these different lifters from different weight classes is going to be different. What they have done is optimize the bar path that's going to fit them most specifically. They're going to optimize the path of their motion to maximize the effectiveness of that movement and minimize the risk of injury or missing a lift. Same with the overhead press. Look at it. Now, if you look at the path of the bar, when she's done pushing the bar overhead from point A to point B, it travels in a curvilinear path, but that distance, we could actually measure how far that bar moves from the top of her shoulder to moving overhead. So it's curvilinear and rectilinear. Now, rotary motion is if a point within a system is restricted or secured, so that system has to rotate around a point when it moves. And that point that it rotates around is called axis of rotation. The resultant motion is called rotary motion. An example of this, a simple example would be a bicep curl. If you look at that, look at the elbow joint. That's the axis of rotation. The forearm is attached to that. We would have a dumbbell or barbell in our hand, and we go through the entire range of motion. It travels in a circular path. That's rotary motion around a fixed point or axis of rotation. Now, general motion, this is considered what they call normal human movement. It's all the previous types of motion combined to enable human movement. We run, walk, lift, carry, squat up and down, bend, twist, push or pull, bend, twist, sit, stand. I guess I said that twice, didn't I? Bend, twist. But anyway, you get the picture. And we could do various combinations of these. We're moving ahead, we're forward and backwards, side to side, up and down, rotating through all these different planes of motion, but that's human motion considered general motion. In this whole body frame of reference, everything starts once again from the anatomical position. The original anatomical position was with the hands, palms pointed straight ahead and the arms at the side. The neutral position is more of a normal body position. The palms are actually pointed inward. If you're standing here, that's how we normally stand. Most movement now is referenced from the anatomically neutral position. However, most of the textbooks you have still go from the original position. However, if you logically look at it, we would go from the neutral position because that's how normal human motion starts from. Now, the cardinal planes of motion with the associative axis of rotation, we have the sagittal, frontal, and transverse plane, along with the different axes of rotation along with that. So we'll go into that more, but I want you to see how this works. If we look at the sagittal plane, which means we cut the body into two equal right and left halves. So if we do flexion extension, if we raise our arm up in front of us and then down again, that's flexion extension. It's moving through the sagittal plane around a medial lateral axis. That means if you look at the axis that the shoulder rotates around, as we do that flexion at the shoulder joint, that axis of rotation is perpendicular to the plane of motion. Movement through the sagittal plane is around a medial lateral axis. Now, frontal plane, we would like putting our arm out to the side and moving our leg out to the side as well. That's moving through the frontal plane. It divides the body into front and back halves. And the axis of rotation, once again, all axes of rotation are perpendicular to the plane of motion. That would be an anterior, posterior axis, a front to back axis. Now, transverse plane would be if we just rotate our body. If we're standing there and we put our arms out to the side and we rotate left and then back right again, that's around a longitudinal axis. If we look at multiplanar movements, these are ground-based movements that cut through the various planes of motion which we just described. Swinging an object. If you look at the one person over here that's swinging or pounding the tire with the hammer, he'll cut through various planes of motion to get through that. If you look at the golfer on the right-hand side, they'll swing through multiple planes of motion. If you look at the tennis player, they move through all those as well too. Playing basketball, the people that try to move the ball, somebody's trying to block their paths when they're holding the ball, they'll move all kinds of different ways, but that's through various planes of motion, and that's called multiplanar. So how does this all pertain to flexibility? It has everything to do with it. You must know how the kinetic chain is put together and how it operates. So once again, if you look at biomechanics, we have kinesiology on one side, the study of human movement, the kinetic chain that's associated with movement patterns, and that's structure and function. The other side are the movements themselves and also the forces that cause movement. So if we look at that, we have to know all the origin assertions of all the muscles, what joints they cross, and what these functions are. This information will assist you in identifying any movement deficit that impedes effective movement. So when we do like a posture analysis and a range of motion analysis on somebody, we'll look at all the joints to see what muscles are tight, what muscles are loose, how it affects their posture, and also, too, if you're trying to do a specific motion, then guess what? If you have something that's really, really tight, then you're probably going to rotate to that one side. That's going to cause a movement deficit, or what we call a substitution pattern. If you keep doing that substitution pattern, you're going to end up with an injury in the long run. That's what we're trying to do here. Now, flexibility basics. Range of motion is joint specific, depending on the type of joint structure. The body acts as a kinetic chain. Tightness or looseness in one area can affect the spine. We're going to get to that because if you look at the spine, the arms and legs are attached to that. So if the spine doesn't move properly, the arms and legs won't move properly at all as well too. The injured joint is often the victim, not the culprit. Because if you look at a joint, we know that it should move through a specific range of motion. But if the surrounding structure, like ligaments, ligaments that hold the joint together and muscles that cross the joint, if they're impeded in any way, it could cause that joint not to move through its entire range of motion, and this could cause the problem. Now, this depends on a movement at a specific joint relating to what movement is being performed, i.e., what exercise you're doing, how much load is on the joint, proper technique, etc. And for all this, the sacrum provides a foundation for the spine. Positioning is integral to function. If the trunk is strong and stable, the arms and legs operate efficiently and effectively. Muscles that control the hip range of motion originate on the pelvis or spine and insert on the femur. So if you look at that, if you look at the pelvis, the sacrum is in between the ischium and the ilium as they hold it together. And those are specific joints there as well too. Now, if the muscles that cross the hip range of motion originate on the pelvis and spine and insert on the femur, if any of those muscles are tight, it's going to put the pelvis in the wrong position. And that could affect efficient range of motion and efficient movement very, very bad. So let's look at major range of motion for the range of motion for major joints. We just talked about the vertebral column. Let's look at the skeleton there. What do we see? We see the arrows are pointing to the vertebral column, and it's also pointing to the sacrum and the pelvis because, like I said, the pelvis has three different bones, the ischium, the ilium, and the pubis, but in between those, what holds it together is the sacrum. So if we look at it also too, upper extremities, we have the shoulder girdle, which is what we have the scapula, the shoulder blade, and the arm. And the arm, the humerus, moves at the shoulder joint. And within the shoulder joint, we have two specific joints called the sternoclavicular joint and the acromion-clavicular joint. And also the arm also has the elbow, wrist, and hand. All those have joints as well. And then the lower extremities, we have the legs that are attached to the pelvis. And the leg is attached by the hip to the pelvis, which also has the knee, ankle, and foot. So you can see just by looking at the skeleton, we have lots and lots of joints in our bodies. And if you know how all these are put together and know the range of motion at each of these joints and all the muscles that cause movement at that joint, you're able to analyze human movement much more effectively and efficiently. Now, the trunk and the spinal column, the vertebral column is extremely complex. It has 24 intricate and complex articulating vertebrae. It has 31 pairs of spinal nerves, and it's the most complex part of the body other than the central nervous system. The vertebral column itself has 24 articulating and 9 fused vertebrae. 7 cervical, 12 thoracic, 5 lumbar, which is the lower back, 5 sacrum, that's the posterior pelvic girdle vertebra, 4 coccyx, the tailbone vertebra. The first 2 cervical vertebrae, however, their shapes allows for extensive rotary movements of the head side to side as well as forward and backward movements. Now, the vertebral column, most of the movement occurs in the cervical and lumbar regions. There's some slight thoracic movement, but not a lot. Now, the movements of the head, we have movement between the cranium and the first cervical vertebra and within other cervical vertebrae as well. Referred to as cervical movements. Kind of common. Now, the trunk movements, we have lumbar motion terminology that describes combined motion in thoracic and lumbar regions. For cervical region, the head will flex 45 degrees, extend 45 degrees, laterally flexes to the side 45 degrees on each side, and rotates approximately 60 degrees total. Now, the lumbar spine, including trunk movement, it flexes approximately 80 degrees, and it extends backwards about 20 to 30. So if we look to the very left, it extends, hyperextends about 30 degrees. And if we're laying down on a flat surface, it rotates about, it'll extend about 20 degrees. So depending on what your environment is. So if you look at the movement to the right, how it will flex forward, it's about 80 degrees. The lumbar spine, including trunk movement, the lumbar lateral will flex to the side 35 degrees on either side. And if you're looking over top of a person, it'll rotate 45 degrees either way. We've talked about the shoulder girdle. And then, as I said before, it's the scapula and the clavicle put together, and they're attached to the manubrium of the breastbone. It moves as one unit. The clavicle's articulation with the sternum is the only bony link to the axioskeleton. Now, I'm going to tell you now, if we look at this, if you look at the upper arm, the humerus, it's attached to the glenoid fossa, the glenoid cavity. The only way when we start to raise our arm up to a certain point, the scapula starts to elevate and upwardly rotate to position the socket, this glenoid cavity or fossa, in the right position, so the humeral head will roll and glide in that appropriately. Now, you're going to get movement at the SC joint, the sternoclavicular, the clavicle that it's attached to manubrium. We're also going to get movement at the AC joint. If I take my arrow, here is the sternoclavicular ligament. Here is the AC joint, the acromion-clavicular ligament. There, those two bones put together. As the scapula moves upward, it'll elevate like doing shrugs, but this inferior angle here will rotate out to the side, and this position here, the glenoid cavity, will rotate upward and position this socket so the humeral head of the arm can move in the proper position. Now, we also have to look, another joint in there is what they call the scapulothoracic joint. The scapula moves actually on the rib cage. So if we look down here, the scapula, it is in parallel with the rib cage. So if we take this arm and raise it up out to the side, the scapula will rotate about the SC joint, but the shoulder blade will move along the rib cage. Joint motion occurs at the sternoclavicular joint and to a lesser amount at the AC joint, but this shoulder blade moves in parallel along the rib cage. The SC joint, it's a multi-axial joint. Its movement in relation to the manubrium right here. The clavicle moves anteriorly 15 degrees with protraction. So if you're standing there and you move your shoulder blades away from the midline, like pushing your arms forward, that is protraction. It moves about 15 degrees at this joint right here, where the big blue arrow is. That's where it'll move 15 degrees forward. Posteriorly, it'll move back to its position, and then if you retract, pull your shoulder blades together, it'll move 15 degrees at that particular joint as well. Right in here, it'll move 15 degrees forward, 15 degrees back. Superiorly, if you elevate the shoulder blade, the clavicle will move 45 degrees upward, and with depression, it goes back to its normal position. But if you really depress the shoulder blades, it moves downward about 5 degrees. And there's some slight gliding motions in there too, because it has to roll and glide in this socket to be in the right position. Now, the AC joint, acromion-clavicular, is a 20 to 30 degrees total gliding and rotational motion, which accompanies other shoulder girdle and shoulder joint motion. This particular area, the AC joint, where the big blue arrow is, that's where most of the injuries take place. Now, the elbow and radial ulnar joints, it's most upper extremity movements involve the elbow and radial ulnar joints. It's usually grouped together due to the close anatomical relationship. The elbow joint movements may be clearly distinguished from those of the radial ulnar joints. We're going to look at that. And the radial ulnar joint movements may be distinguished those from the wrist as well. So here is the elbow joint. If we look at that, it looks like a big ratchet, could be a ratchet wrench, but it looks like more like a crescent wrench. That is the ulna. Here is the upper arm. If we look at the humerus, it's got this round parts at the bottom. And if you look at the ulna, it's got a big notch in there, and that looks like the crescent wrench. These two fit together. The ulnar joint is the radial joint is right here. It doesn't hardly touch the humerus at all. It's a hinge joint type of movement. The elbow is a hinge type of movement and allows basically only flexion and extension. It has two interrelated joints, the humeral ulnar joint and the radial humeral joints. Now, as the elbow flexes about 20 degrees or more, its bony stability is unlocked, allowing a little bit of side-to-side laxity, but not hardly at all. The stability when flexing the elbow, stability and flexion is more dependent on the lateral and medial ligaments, the radial collateral and the medial ulnar collateral ligament. That's what holds that joint together on either side. Elbow motions primarily involve movement between the articular surfaces of the ulna and humerus. Remember, here's the humerus and here's the ulna. Specifically, the humeral trochlea fitting into the ulnar trochlear notch. Here's the trochlear notch right there. And the humeral trochlea fitting into there. These two bones fit very nicely together. The radial head is a relatively small amount of contact with the capitulum of the humerus. So if we look right here at this joint, here's the radial head. It has very little contact with the upper arm. As the elbow reaches full extension, the olecranon process right here, it's like the end of the crescent wrench. It is received by the olecranon process in the back of the elbow joint. The back here. As you extend this arm straight down, there's a notch back there that this olecranon process, and all the process is an extension of the bone, something that sticks out from the bone. The process. It fits into this little notch in the back. This is increases joint stability when the elbow is fully extended. Now the elbow moves from 0 degrees. Here's from 0. If the arm is straight out and the elbow is locked, the arm is straight, it moves from 0 degrees to about 145 to 150 degrees of flexion. Now the hip joint, there's some disagreement about the exact possible range of each movement in the hip joint. And it moves from about from 0 to 130 degrees of flexion, depending on what book you read. So if you look here, if we're laying on our back, if we flex the hip, it moves about 120 degrees. If we're laying on our back, it'll extend, hyperextend about 30 degrees. And once again, even if we're laying on a table with our hips over the end of the table, it'll still move and it'll still extend about 30 degrees. Now, for abduction adduction, if we're moving the leg away from the body at the hip joint, it moves about 35 degrees away from the body and inward past 0. If you look at, here's the neutral position, it will adduct to about 20 to 30 degrees, depending on the person. Now, if we look at internal rotation versus external rotation, if we flex the hip with the knee pointing straight out from the hip, if we move our foot out to the side, that is considered internal rotation because the knee joint right here is moving inward. The foot's moving outward, but the knee's moving inward. And if we move our foot, move to the midline, the knee will rotate to the outside. Same within the prone or supine position. In the prone position, if we're laying on our stomachs, if we move the foot inward, that is called external rotation because this part, the knee, will move outward. And the same with the internal rotation. The foot will move outward, but the knee rotates inward. Now, if we're laying on in a neutral position and on our backs in the supine position, we can externally and internally rotate the entire leg as well. So we have 45 degrees of internal rotation and about 50 degrees of external rotation at the hip joint. Now, the pelvic girdle moves back and forth within 3 planes with a total of 6 different movements. That's the pelvic girdle. 3 planes of motion, 6 different movements. And all pelvic girdle rotation results from motion at one or more of these locations: the right hip, the left hip, or at the lumbar spine. So if we look at anterior and posterior pelvic rotation, if we're looking at the pelvis from the side, it's moving in the sagittal plane or anterior posterior plane. Now, if we look at anterior rotation, we see somebody that's got a big, like they've got a big sway back. They're looking at that. That's anterior pelvic rotation, where the top of the pelvis will move forward. It's accomplished by hip flexion and or lumbar extension. Now, posterior pelvic rotation is when the top of the hips move backward. It's accomplished by hip extension and or lumbar flexion. Let's look at right and left pelvic rotation. So if we're looking at the front of the pelvis, we're looking at somebody from the front, we have left and right pelvic rotation. In other words, it's in the frontal plane, and if we look at the left side, this means we're just going to raise the hip up and out to the side. So if we look at left lateral pelvic rotation, it's accomplished by left hip abduction. We're taking the hip and raising the left hip upward. That's abduction, meaning away from the midline, which means the bottom of the hip will move outward. And that causes right hip abduction, where the lower part of the pelvis will move toward the midline right here. Now, if we look at it we're looking at somebody from the over top, looking at from the head down. We have clockwise and counterclockwise pelvic rotation. It's in the horizontal or transverse plane of motion. So if we look at it, here's the front of you, here's the back. So if we look at the front part, if we look at left pelvic rotation, the front of the pelvis will be accomplished by right hip external rotation. This is extending outward. External rotation, left hip internal rotation. So if we look at the hip right here, this is moving inward, and the right hip is moving outward. It's moving away from the midline. Now, what are some factors that affect range of motion? Well, genotype. And genotype is just the organism's full hereditary information. This may limit improvements in flexibility regardless of training. So we may all have the same parts in plumbing, but how it works is going to be different with each person. Now, age is going to be a definite factor in range of motion too. We have a general decline in range of motion with age. Is this due to normal aging? Yes. Is it due to inactivity? Absolutely. But it also has to do with a lot. All these are combined together. Aging, inactivity, it all affects range of motion. Sex, that's males or females. Females generally demonstrate more range of motion than males. It may be due to physiological causes, that is, differences in skeletal structure. If we look at the skeletal structure of males versus females, especially in the pelvic region, females have a shorter pelvis, but it's wider. Males have a higher pelvis, but not as wide a pelvis, but it's definitely taller. It's because women are built for childbearing, men are not. Other factors that affect range of motion are posture. If we look at today's society, we're always in front of a computer, or we're sitting down texting, we're driving, we're not standing up and trying to go from Cro-Magnon to Homo sapien. Now, if we sit down all the time, we're not using the full range of motion at all the joints on a regular basis, and this causes our tissue to shorten. So if we're sitting down at the computer all the time and we're rounded forward, our keypad is up too high, the screen is down, we're going to hunch forward. So if we look at all the tissues on the front side of the body, they're going to shorten. And all the tissues on the back side are going to lengthen. And we're going to, all our shoulder blades are going to move apart and everything's going to be crunched forward. Now, this is going to be difficult to correct because we have a lot of ligamentous creep. In other words, the ligaments and the muscles are all going to shorten. We're also going to get disc creep at the vertebral column as well. Other factors affecting range of motion, arthritis. This affects the articulating cartilage, which is avascular. It doesn't have its own blood supply. Now, when damaged, the articulating cartilage may be replaced with fibrocartilage or bony spicles, which means diminished movement. This is in the fingers, toes, shoulders, hips, knees. These are all common areas for this type of arthritis. Now, the two common types of arthritis, one is the biggest one that causes the most damage is rheumatoid versus osteoarthritis. This affects only a few joints, and the polyarticular affects many joints. It's most common in women and typically diagnosed between ages 25 and 60. And they believe that rheumatoid arthritis is an autoimmune disease. Now, osteoarthritis, this is what affects 90 to 95% of all arthritic cases. It's usually a disease of aging, may be caused by a previous injury or mechanical derangement. If we look at a lot of athletes, they've beaten these joints to death through full range of motion, a lot of impact forces. It's just loading that joint and moving through its range of motion. It basically is just going to wear the joint out, and this is where the arthritis can set in, because especially if you have a genetic predisposition to have osteoarthritis. Exercise helps increase blood flow to the muscles in the surrounding areas, which helps with nutrient diffusion to the avascular cartilage. Remember, cartilage doesn't have its own blood supply, but if you can increase the blood flow around the joint, it can diffuse into the joint, and all these nutrients can diffuse in and help decrease pain and help rebuild the cartilage. Reduced activity in most circumstances results in continued deterioration. An example, if we look at the posterior ligaments between two vertebrae, there's a referred to these. If you look at each vertebra, we have the top part of the facet joints, anterior, and we have posterior facets. The one below here, this is what they call an anterior facet. It hooks in with the top vertebra, the one above there, but it also joins with the upper vertebra's lower facet joint right here. Here's the inferior. Here's the anterior, or the inferior. Sorry, I can't get my words right here. Here's the top part, the anterior. Here's the inferior. They join together. There's also a capsule around here, and in between that is a joint cavity. Now, these facet joints are synovial joints and have articular cartilage. If this cartilage is damaged, this is where the arthritis is going to set in, and that can decrease the range of motion of each one of these facet joints and cause a substantial amount of pain. Now, osteoporosis, you get a loss of bone mass. Osteoporosis, it's a loss in bone mass or bone mineral density. It's much more common in women, especially after menopause. It may be genetically influenced as well. Common sites are hip, wrist, and vertebra. Commonality in location is presence in the spongy bone. It happens in the spongy bone of any kind of long bones. So if you look at a femur, the middle part there is the compact bone, and the ends of the bones are what they call spongy or cancellous. This grows. The only way this is going to grow and get thicker and get more dense is to load the bone appropriately. But as we age, our bodies are leached of calcium and potassium. So what's going to happen is, and if you don't load this bone appropriately, it's not going to grow and stay strong. Now, exercise, especially weight bearing or resistance training, may help increase cancellous bone density. Next, we have basic assessments. Now, let's keep in mind, too, These assessments that we're about to go through are from the book that are about basic low back and lower body assessments. However, I've added in a couple other ideas that we could utilize as well. So I've just added to what they had in the book because I thought the book was a little light on what you should be knowing. So let's go from here. All right, so we look at the posture overview. You can see from the left-hand side, this is from Kendall's book on posture, muscle function, and testing. So if we see, we have ideal alignment, we have kyphosis, lordosis. So the kyphosis, lordosis, you can see the upper back is kyphotic, and the lower back, you've got that anterior tilt on the pelvis. The flat back posture, you have an posterior tilted pelvis, and there's actually no curvature in the low back. And the sway back posture, they've got a little bit of low back curvature, but the upper back is more kyphotic, and that's what they call sway back. Now, that's from the lateral view. From the posterior view, you can see good, moderate, and severe problems with posture. And from the moderate and severe, this is what I've seen a lot in a number of people that I've tested over the last 12 years. Now, posture analysis is defined as the relative arrangements of the body parts, i.e. optimal muscle lengths and skeletal positions. Look at that word, optimal muscle lengths and skeletal positions. And for posture analysis, you should do multiple positions, front, side, and rear. So if you see this one gentleman that I was reviewing, he was a tennis player. So you can see he's just got one side that's actually not too bad. His front side is not, his front view isn't too bad. The midline axis is pretty good. His side view, the midline axis is pretty good too, so it doesn't look too bad. His hands are rotated a little bit. If you look at the front view too, since he's got that shoulder tilt angle up about 4.5 degrees, you can look at his left and right hand positions. The left side is actually higher than the right side. From the side position, it's not too bad, but then let's go to the back side. It just supports what we saw on the front side. His head's rotated just a little bit. He's got that scapular angle. His hip shoulder has a tilt and a rotation. Midline axis isn't too bad, but once again, you can see the differences in the hand positions. Not only one's higher than the other one, but one is forward a little bit more. So these are the things you need to be really looking for. This is this is a 12-year-old athlete that played football. So you can see this is his postural frontal view. He really leans to the left side. Look at the angles of the trunk, the left shoulder elevation. He shifts to the left side. Left hand is higher than the right, consistent with the shoulder height. So you can see, just looking at him, the midline axis is really off. From a lateral view, he's got slight sway back with a little bit of rounded, but look at his shoulder blade protrusions, and the head is tilted forward as well. And also look how his feet are in tandem with each other. This is how he stands. This is how he feels normally. From the backside position, it just supports the front. He's got that rotation, the shoulder blade depression, and the shoulder blade protrusion. Look at how he supports to the one side. His hips are going to the left. But it looks like he's leaning toward the right at the lower position, and he's got that left ankle pronation. So these are the things we are going to look at, because just by looking at it from a posture point of view, you can get an idea of what the whole kinetic chain, how there's some deficits throughout this entire kinetic chain. Now, good mobility of the spine and muscle control are essential activities of any kind of locomotion. Decreased range of motion in spine or supporting structures are linked with increased potential for low back pain. Extension in the spine is likely to decline greater than flexion. Let's say that again. Extension in the spine is likely to decline greater than flexion. Now, active extension should occur within range of normal lumbar lordosis, which means in a standing position. Now, we talked about this before. The lumbar spine flexes about approximately 80 degrees and extends 20 to 30 degrees. Now, what about lumbar movement? In the forward movement of the trunk, lumbar flexion per se doesn't really occur. these 5 lumbar vertebrae don't move very much, but they can based on where the pelvis is. What some may view as lumbar flexion is essential a removal of the lordotic curve. Also, too, you can add in if that pelvis tilts anterior or posterior, it can cause some problems here in the lumbar area. Now, the range of motion of the spine, the spinal flexors, what are they? They're the rectus abdominis because the lower abs will pull the pelvis forward. The spinal extensors, if they get shortened, let's say if you have anterior tilt of the spine, if we look at right here, this is the front part of the spine. If that's tilted forward, that means the lower abs are very, very weak. The hip flexors themselves are tight, but so are the erector spinae. Because as this tilts forward, these contract, these get tight, these lengthen, and the hamstrings lengthen as well too. When we're measuring spinal range of motion, we have 2 categories. We have passive trunk extension and we have the active trunk lift. The passive trunk extension is just an indicator of range of motion only. Now, when you're laying down on the floor, you're laying prone. Your front side's down on the floor. And the pelvis itself is going to be flat on the ground. And we're looking at the very top part of the pelvis, which is the anterior superior iliac spine. It must remain in contact with the floor. And sometimes those with longer trunks may have higher scores. In the active trunk lift, the range of motion along with extensor strength is reflected in the test score. Those with longer trunks may have a higher score as well. So if we look here, here's the passive trunk extension. You lay down on the floor and then you just basically, you're relaxing and just push away from the floor to see how far your trunk can come up, how much it'll extend with your pelvis being flat on the ground at all times. If the pelvis comes off the ground, the front part of the pelvis, the ASIS comes off the ground, that means that's where you stop the test. Now the active trunk extension, the hands are at the side, hands and arms are at the side, and once again, you're trying to pull the chest as high off the ground as you can without the pelvis moving at all. Now let's look at the iliofemoral joint. Muscles that cross the hip joint may limit movement of pelvis by bracing in if they are too tight. This is what we were talking about before. So remember, we saw this picture here in the upper right-hand corner. That's normal range of motion or normal length of these muscles that hold the pelvis in neutral. If we look here at the middle diagram with a neutral pelvic motion from the lateral view, the ASIS, the anterior superior iliac spine, is in line with the pubis symphysis. Sorry, I moved it. But so look at that. Now, if we look at the anterior tilt, that means the lower abs, the rectus abdominis, are weak. And the psoas muscle, iliopsoas, is really tight. So what it's doing, it's pulling on the spine where it's attached at and pulling the lumbar region forward. And the pelvis is going to tilt forward too, which means the erector spinae on the back side is going to tighten up. It's going to tilt the pelvis forward. On the posterior tilt, we saw in one of the lateral views of the spine that these are lengthened and the erector spinae are lengthened, and so are the hamstrings are tightened. So it's pulling the pelvis in a posterior tilt. The abs might be activated as well too, because if they're getting tight, they can pull this pelvis forward. So like I said, muscles across the hip joint may limit movement of pelvis by bracing it if they're too tight. In this case, trunk muscles, regardless of development, may be unable to control pelvis position. So we were looking at the hip flexors, which are the psoas major and the psoas minor. Can produce anterior or forward tilt if the range of motion is decreased, which means it's going to have increased lordosis. Now the hip extensors are the glutes and hamstrings. They can produce posterior backward tilt if the range of motion is decreased, as often seen in reduced lordosis. The IT band on the side, they cause reduced range of motion and may limit adduction of the thigh. In other words, they can pull them out more. You can't pull them in. You can't move the leg toward the midline of the body. The piriformis, which is an external rotator, it may reduce range of motion, may limit outward or inward rotation of the femur. Now, if we're going to measure this, we're going to measure hip range of motion. We have these tests. We have the Thomas test, which measures tightness of the hip flexors. Passive and active knee extension measures tightness of the hamstring. The Ober test looks for IT band tightness. And then we have the Piriformis test, which measures piriformis tightness. Now, testing for IT, ITB, and piriformis tightness can be done, but these tests are much more difficult to perform. But we're just going to give you an idea of what to look for. Now, the Thomas test, this is from your book. If you lay down on your back with your head down, you have to push the pelvis into the ground, put your hands behind your knees, and pull the leg toward your chest. However, we're looking at how much your other leg that is flat on the ground, how much it will rise off the ground. That's how you can tell your IT band test. Or not IT band, but your iliopsoas. Are your hip flexors too tight? Let's look at another one. So this is what we're doing there. Here's a Thomas test laying on a table with the leg hanging over the top, hanging down. Now, this young man can pull his leg toward his chest. His pelvis doesn't come up because his hip flexors are okay, but look how his leg sticks out. Now remember, if you know anything about muscles origin and insertion, the rectus femoris, one of the thigh muscles, crosses the hip joint as well as the knee joint. Now, if that's tight, you may have at this end be able to keep the pelvis on the ground and the leg on the ground right there. Because if it popped up, that means those hip flexors are really tight. But in this particular case, the rectus femoris, which crosses the knee joint and the hip, it's tight. That's where the leg is sticking out. That's one of the tests we can tell for that particular hip flexor and to see how tight it is. Because that leg should be hanging down at 90 degrees. In this particular case, it sticks out, so we know that particular quad muscle is very tight. Now we have the passive straight leg raise. If you hold the leg down, they push the lower back into the ground, and you're passively raising the leg. Now what you're looking for here is they relax this leg, and you grab their leg and you push it up until you feel a tightness in the leg. That's passive. And it could be, a lot of people are way down in here. This one is almost at 90 degrees. Now, when they start to feel a substantial tightness in their hamstring muscles, then that means that's the range of motion from a passive leg raise. Also, too, they may want to point their toe because of the fact that the calf muscle crosses the knee joint and can inhibit you being able to raise your leg up. Since it crosses the knee joint, it can inhibit that range of motion at the hip. This is the passive active leg raise. What we're doing here, I'm holding this young man's leg and I moved it up this way. He relaxed it and I'm moving this leg toward his head, and this is where I felt a lot of tightness in his leg. The leg stopped since the hamstring tightened up. This is all it was. Then, that's the passive. Then I asked him to tighten his quad and pull his leg toward his head. And it only increased by 4 degrees, which means this young man has substantially tight hamstring muscles. And you do this on both sides. Now the active knee extension, we're looking at, so if you do this, she lays down, leg down, and she pushes her low back down, and she's looking at knees at 90 degrees. So as she extends her leg, you'll be able to tell how tight the hamstrings are by is she able to really extend her leg all the way up. Now the Ober test will test inward and outward rotation of the hip joints. So you do it upward and then you go downward. You got to see, she has her hand right there. So you have to have that reference point and then rotate the leg inward and outward to test for this to see what the range of motion is. Now the Piriformis test, you do this. You put the leg up, hold the leg at 90 degrees. This leg should be laying on the ground. and you do inward and outward rotation to see what the range of motion is at the piriformis. So you do it on both sides. You do it on both sides and inward and outward to test to see the ability to externally rotate the leg. Now, if you have combined tests of the range of motion in trunk and hip flexors, you have the sit and reach test. Now, this is a better indicator of hamstring flexibility than low back flexibility. Now, this test may increase the risk of injury with those with tight hamstrings. It also may increase intervertebral compression forces on the disc. Nicalier offered an alternative test to reduce this stress. It's a protective hamstring stretch, and we're going to look at that. But remember, this test has a lot of controversy surrounding it. So we're going to look at it, then we're going to explain what we mean by that. Now, this is the first sit and reach test, the Nicalier protocol. Now, what you can do is to see this leg is down, this leg is bent, so you can test one side at a time. And what they're trying to do is keep this leg down and move forward to see if they can touch their leg to see do they have hamstring flexibility. However, there is a drawback in this. Now, the sit and reach test does not allow for proportional differences between arm and leg lengths. Now, Hopkins and Hosner offered an alternative design that may not improve validity. Tightness in connective tissue behind the knee and sciatic tension may limit performance in the test. So we need to look at the modified back sit and reach saver. And it's also allowed, now, once again, we talked about that. Allows for passive plantar flexion. In other words, we move we flex the ankle joint, pushing the toe forward, and this activates the calf muscle. So when you're doing this particular test, this is what we were talking about before. When you're doing that passive leg raise, that you need to point the toe because since the calf crosses the knee joint, it could give you a false indication about the flexibility in the hamstring. Now here's a second sit and reach. So you actually have a device. You put your feet flat on here, you put your hips against the wall, and what you do, you got to keep the leg straight, and you push this little lever here forward as far as you can. That gives you an idea of there's certain numbers on there to say, okay, between these certain numbers you get either a poor, fair, good, or excellent range of motion of the hamstring muscles. The third sit and reach is the modified back saver too, so you can sit them on a bench, bend the one knee, put the other leg up on there, and see how far you can move forward you can set the rod, or you can set a yardstick right there to see how far you can move this, and you can set your own protocols for this or numbers to see how far forward they can move. Now, considerations for the sit and reach. The number of centimeters reached may not be the best indicator of performance. It examines quality of movement, so we have to look at the angle of the sacrum when we do these tests. You also have to examine the smoothness of the spinal curve. You can test one leg at a time, or you can do both. Now, you can design the box as such that the foot is allowed to plantar flex, what we just looked at. So you can look at these and do them in so many different ways. Now, this is where we're sit and reach test, quality points to look for. So if you look at this, here is what it should look like. The back angle right here on B should be straight up and down. The angle should be 90 degrees. So if you look at the femur and the low back, they should be angled 90 degrees. So even here, it's angled 90 degrees, but he can't move any farther because his hamstrings are so tight. Now, if you look up here, his hamstrings are so tight, but even though he can round his back and may be able to touch his toes, he still has a really bad hamstring, and that angle is greater than 90 degrees. And this is what we were talking about before. So if you have a short trunk, long arms, you may be able to touch your toes, which a lot of people think if you can touch your toes, then that's a good test. No. So even if they can touch their toes, you need to be looking at this hip angle right here to see if it's greater than 90 degrees. So you can see this angle right there. See the angle right here with the pubis and the ASIA, or ASIS, they're almost even with each other, causing a 90-degree angle here and here. Here it's back a little bit too because his hamstrings are so tight he can't move forward, but he also isn't rounding his back. So here are some examples. Here's a young man with that, well, like the bottom one. He can he could actually touch his toes, but look at the back angle right there that can be measured. I'm using a system called Dartfish here. So it's a video analysis system, and I can draw all kinds of angles and measure these angles appropriately. Here's that one young man we first did the posture analysis on. He can almost touch his toes as well too, but look at the angle here of his low back compared to the femur. His low back angle is about 101 degrees. This young man can, here again, he can touch his toes, but the angle of his low back is still greater than 90 degrees. And here we have a young man that can actually move forward past his toes. He's got really long arms, short trunk, but he can still achieve that 90-degree angle of his low backs and femur that we are looking for. Now, conclusions of this. You must know the following before performing range of motion assessments. You have to know the kinetic chain, how it's all put together, all the joints, and how they work. You have to know all the types of motion, because any type of motion that you do will involve a joint and the muscles surrounding it. And do you know if the connective tissue around the joint and the muscles surrounding the joint are tight and working optimally? You also have to look at motion through the planes of motion as well. And once again, look at those joint configurations. You also have to learn the basics of postural assessments. You have to learn the basics of all joint range of motion assessments as well, not just parts of range of motion testing. Range of motion testing coincides with teaching the mechanics of exercise, movement. Because if they've got poor range of motion and you're trying to teach them a movement pattern, if each joint cannot go through its full range of motion, it's going to limit range of motion at the bad joint and could affect the entire motion and could lead to substantial injuries. Remember, bad technique accelerates or accentuates faulty movement patterns, which leads to many types of injuries. So please keep that in mind. All right? So we'll see you next time.